Ladies and gentlemen, please welcome to the stage Elizabeth Black.
Hello. It is my pleasure to welcome you to YRMC's 7th Annual Dinner Symposium. We'd like to invite all the guests, if there are still any in the lobby, to find their seats and remind you to please silence your phones. Thank you for joining us tonight. We realize many of you traveled a good distance to be here, and we appreciate your interest in and support of this educational opportunity. We're also happy to have joining us by way of live streaming for the 3rd year, many hundreds more, a larger audience that has included individuals from other states in the U.S., as well as from other countries, such as Mexico, Canada, and others. And one more item we wanted to share. You're going to find that Dr. Tibi is probably going to be arriving this evening just under the wire for his part. He's been working very diligently all day on a very serious medical emergency with a patient. But we feel that you would agree, if you were the patient or the patient's family, you would rather have him at the hospital than here. So we do expect him to make it here, but he's where he needs to be right at the moment. The quest to reach far-off destinations has pushed man to take extraordinary measures. Many, if not all of us, spent some time this summer thinking about that day in July of '69, 50 years ago, when man first walked on the moon. We reflected on that achievement, where we were, what we were doing. We remember it. But we also don't forget the tragic endings of some other quests. Titanic, Hindenburg, Challenger, those all bring vivid images to mind. But isn't it true that between the terrible tragedies and the glorious triumphs, there are journeys, many journeys that are taken every day, many destinations that are reached successfully that largely go unnoticed, unless, of course, you are the one who made it safely, whose life was spared or sustained. Mesaba, Olympic, Virginian, those names probably don't mean anything to you, but those are just a few of the other ships that were also on the oceans on April 15th, 1912, the day Titanic sank. These ships successfully brought their cargo, brought their passengers to their destinations, but most of us don't know the details of those journeys, do we? Well, tonight we're going to take a little time to review and recognize some journeys that were embarked upon in our community that have succeeded, endeavors that have made Yavapai Regional Medical Center a destination for cardiac services and patient blood management. You'll soon hear from some experts in the field of cardiac electrophysiology, interventional cardiology, and cardiothoracic surgery, who will share the advances in their field and the services that they provide through the James Family Heart Center at the West Campus in Prescott. And we'll learn how these directly correlate with patient blood management. Now, for those of you who may be joining us for the first time, we wanted to provide a basic definition of patient blood management, or PBM, the other program that will be highlighted tonight. Simply put, PBM is keeping your blood in you and keeping it working properly. That means we use evidence-based medical and surgical concepts designed to maintain hemoglobin concentration. In other words, make sure your blood is carrying and delivering sufficient amounts of oxygen to your body. We also want to optimize hemostasis, the body's response to blood vessel injury and bleeding. And we want to minimize blood loss in the first place. We could call that KTB-ITP, keep the blood in the patient. Now, these measures are all to improve patient outcomes. PBM is fully aligned with evidence, economics, and ethics, which are certainly the dominant forces in healthcare today. So how do cardiology and blood management go together? Well, if you were asked to name the organ that seems most related to blood, many of you would say the heart, right? After all, it's the pump. It's where the aorta begins, the largest blood vessel of the human body. One could accurately imagine that if your heart required some repair or rebuilding, there would be great potential for blood loss. And historically, cardiac surgeries have been where many, many blood transfusions were commonly utilized. Yet what if repairs could occur less invasively? What if less blood were lost? Or if lost blood was captured, salvaged, and returned to the patient? Reducing or eliminating the need to add the complication of receiving another human's blood in your healthcare would be a worthy goal, wouldn't it? So tonight we're going to learn more about how this is being achieved at YRMC. So again, we welcome you who have joined us here in the auditorium and those joining us via live streaming. Thank you for coming along as we trace this journey, and we hope that when you leave, you will know more about how you and your loved ones can benefit by the good work of so many people in our community that are here to help us have a healthier life. As Neil Armstrong once said about his famous first steps on the moon, I guess we all like to be recognized not for one piece of fireworks, but for the ledger of our daily work. Without further delay, I'm pleased to introduce a man who has contributed to that daily ledger at YRMC, the President and Chief Executive Officer, Mr. John Amos.
Well, good evening. You know, every time I get on a stage, I have absolutely zero musical talent. But something about being up here makes you want to sing and perform. So I'm going to go off script. I'm going to sing my favorite song. No. I had you going there. No, thank you, Beth. And I would just want to share a few words about our team and a little bit about our journey. But before I do that, I want to thank Beth and the entire patient blood management team, the medical staff, all the folks that put the symposium together this evening. Do a wonderful job, and I'm very honored to be here. And I want to thank you for coming, and I know everyone has busy schedules, and it's great to see you here. And I tell you, I think one thing that's so wonderful about our community is that we come together often for many things, and to have you here this evening is much appreciated. So thank you for being here this evening. And I kind of wanted to set the table a little bit about healthcare in our region. And, the history in our community is wonderful. And if you go back to healthcare, there were two nuns on their way to the Arizona Territory in 1878. And they made it into Maricopa, which is, my understanding, is down in essentially the Phoenix area. And the mission determined that Nogales and Prescott would be the outpost, the first reach there for their mission to help provide health care. And so they opened up the Sisters of Mercy Hospital on a Larkin. And some of you may know a Larkin, just right downtown. The original building is still there. And they opened up health care for our communities in 1878. And from that point on, as with our entire area, we've evolved, and Yavapai Regional Medical Center celebrated its 75th anniversary last year, and we are very proud to be your local community healthcare provider. We're a not-for-profit, locally owned and governed healthcare system that is proud to have served our community for over 75 years now. And we're also proud of the fact that everything we do and the decision-making through this journey in our community has been patient-centered and patient-focused. So the decisions we make in the boardroom, with our medical staff, with our team in the healthcare center, can be in our imaging centers and our physician clinics. It's patient-centered. So we look at what decision we make and pair that up to, is this the best thing for our community and the patients that we serve? And we've continued that tradition for quite some time. And we have a talented group of physicians and caregivers in our James Family Heart Center that are continuing to advance cardiac care. They're performing procedures in our community today that very few hospitals that are community-based like ours are able to do. And it's the talent that we've brought together that has allowed us to continue to evolve our program to where it is today. And a little bit about the evolution of our cardiac services. We opened our first cath lab in 2004, and we had a wonderful cath lab director. Some of you will remember Karen Singleton. And I remember when Karen came in to open our cath lab, we talked a lot about the limitation we had is we did not have a full service open heart program. So we had to have Native Air, our helicopter transport system. Anytime we had a patient in the cath lab, we had to have Native Air on campus for that procedure. And we knew that our history, we would need to evolve to continue to advance the services for our cardiac services. So we have now evolved to where we brought the heart program in 2007. And we know who helped us with that. Dr. Pierre Tibi is just a wonderful surgeon. He came into the community to help us establish the heart program a couple of years prior to opening. And he loved the area as we do. And he decided, I think I will stay. And so we were blessed to have Dr. Tibi stay back in 2007 after we opened our heart program. Since then, as you may know, we've evolved where we have electrophysiology services. Our structural heart program followed, and we've continued to evolve and advance services. We're now scheduled to open our third cath lab. And Diane Drexler, our CNO, has informed us earlier today that it looks like a little later this month we're going to perform our first cath procedure in our third cath lab, which is a state-of-the-art suite which will help us. We have advanced technology in that suite that will help us with three-dimensional mapping and technology that we will use in that new suite for the medical center. The developments with our heart program cannot be understated and reflect our long commitment to meeting the needs of our patients. And that's what I talked about a little earlier. These decisions are made with the patient's best interest in mind. And we've continued to evolve, and we are transforming into where we're actually becoming a destination of care center. And we are now providing services for folks outside of our community because of our advancements in our technology and the services we provide and our advancements in patient blood management. Many of our talented surgeons are also now involved in clinical research, which we've introduced to the medical center in the past year. So we now have a research component developing in the medical center, and that will certainly influence the healthcare development in our area for years to come. We're very proud of our patient blood management program, and we have continued to grow in that area and have contributed in the science of that program globally. We have joined the national conversation in countries in Europe, in South America, in the Middle East, where they are looking to us for information on advanced services where you minimize blood loss and you use advanced technologies with surgical procedures. And I think today the blood management program is just a great example in the core of who YRMC is. It's a program that will continue to evolve with technology in order to meet our community's needs. Our leadership is on solid ground. You're going to hear from a wonderful panel in the symposium tonight on how they're contributing to what we are providing with our patient blood management services as well as our cardiothoracic services. And I'm very pleased and honored to be a part of the team this evening. And in closing, I just want to thank you on behalf of the Board of Trustees, the medical staff, our nurses, all of our ancillary clinical staff, all of our employees, and our over 700 volunteers that support the organization. We appreciate your interest and your support in in the medical center. And you're in for a wonderful evening. You're going to get some great information. And I want to thank you again for attending. Thank you.
When we trained, we were all trained to always transfuse. Your blood gets low, you're anemic, you transfuse. I mean, it's still very hard not to look at those numbers. However, we learn more, and the research provided by the blood conservation team, it just increases risk and danger for all our patients, and not only for open heart surgery, for all surgeries. And it's just getting out of that mindset, but studies and data have shown people do better without unnecessary blood transfusions. Small personal note, my father had open heart surgery many years ago, and he received blood because his blood count was low. Unfortunately, he developed hepatitis C, and that led to chronic problems for the future, and that always stuck with me. And I look at what we do now and compare that to back then, and he probably would have made it a lot longer in life had it not been for that transfusion. So certainly I think not only personally but scientifically it's very advantageous.
Ladies and gentlemen, please welcome to the stage Dr. George Risk.
Good evening, everybody. It's wonderful and an honor to be here, and it's wonderful to see so many people here at this program. We have many exciting things to discuss. My part is going to focus on how we got this journey, how we got this heart program to where we are now. And I think I can safely say I'm probably been here the longest as far as the heart program. Yes, I know I don't look too old, but thank you so much. And I arrived here in 1995, and I think you remember this movie back from, I think it was the late 80s, If You Build It, He Will Come. And that was a Kevin Costner movie, The Field of Dreams. And this farmer in the middle of Iowa had this vision, and this voice talked to him about building this huge baseball field in the middle of nowhere, in the middle of Iowa. And he ended up fulfilling his vision and his dream. And believe me, back in 1995, when I came to Prescott, I thought I was in the middle of nowhere at times. However, it was a beautiful beginning. But, you know, I think we can extend this and say, if you build it well, they will never leave. And I think this is a program we have greatly accomplished here, not only from one person, but from many. And just to give you a little history. So I arrived in 1995. There was 3 of us cardiologists. I brought transesophageal echocardiogram. That's a scope procedure, as what the gastrointestinal doctors, they place a scope in your stomach, they have a video camera. We had an ultrasound on the end of ours, as we do heart ultrasounds from the outside. This procedure has become vital to cardiology, cardiovascular surgery, as you will well see with our speakers later in the show. It's a vital aspect to leading to our open heart and structural, and as well as our electrophysiological program. This wasn't enough. I mean, we wanted to expand. We had a huge patient population of elderly retired people. And so that increased the rate of heart disease here in this city. We wanted to do more. Our patients were going to Phoenix, of course. We didn't have the facilities here. So in the year 2000, we opened up our cardiac catheterization laboratory. We were very cautious. We started doing regular, simple heart casts, nothing too complicated, and we built on from there. And in 2002, we wanted to take a step further. We started doing heart artery stents and interventions, as you hear plenty about today. Then came open heart. Again, we weren't satisfied. We wanted to provide this service for our city, for our patients. We wanted to take care of them. Phoenix had great physicians, and they had great facilities, but this is something that was dear to us and meaningful to us to keep our family here. So we consider all our patients family. So in 2009, we started the open heart program. I was in Phoenix for a year in 1998, 97, 98. That's when I met Dr. Tibi. And we developed a close relationship, and I'd like to say he's one of my closest colleagues as well as one of my closest friends. And he started coming up to Prescott to see patients because we had a volume of patients. We had a good amount of patients going down to Phoenix. And he saw this opportunity to help us out. He was chief of Good Sam then. I mean, he was well known in Phoenix, but he started coming and doing clinic here in Prescott. The relationships build, and we're blessed to say in 2009 we opened up our open heart program, which has been about 10 years, or just over 10 years. And I'm proud to say that the first patient we did is still alive and well, thank God. So we've done very well and expanded from there. This is just a picture of our cardiac catheterization laboratory, which I think John Amos was explaining. We have state-of-the-art equipment. This is our baseball field. So this is a baseball field we were dreaming of back in the late 90s and when we opened up the lab. But we wanted to go beyond. So when Dr. Tibi gave us the honor and came up and opened up our program, he also brought the blood management program. And that opened our eyes. That opened such an awareness to this program and to any program, actually, which you'll hear more of later tonight. But it heightened the care, it heightened our quality as far as what we need to do for our patients. So, and Dr. Tibi's authority on blood management and has really been a national as well as an international leader and speaker on the blood management program. In 2015, we opened up our electrophysiology program. Heart rhythms is a large volume of our practice. We deal with heart rhythm, different types of heart rhythm problems every day, and it's almost like every third patient has something called atrial fibrillation, which you're going to hear about more from Dr. Tung. Dr. Tung joined us from Phoenix. She graced us with opening up the electrophysiological program, and it continues to grow. And you'll hear, I won't steal her thunder, you'll hear from her more here just after me, as a matter of fact. Again, we wanted to provide more for the patients. Cardiology is expanding faster than many other specialties. I mean, technology and techniques, and we opened up doing our first transcatheter aortic valve, and that's a non-surgical valve technique you'll hear more about later also. It's where we place the valve up through the arteries and replace the aortic valve. We started in 2016. From there, we jumped off of that program to our structural heart program. And our structural heart program continues to evolve. Dr. Sindos Moala, one of our speakers also tonight you'll hear from, I won't take much of her speech, but she will describe procedures such as Watchman, atrial septal occlusion, MitraClip. And then in 2019, the team did the first transcatheter mitral valve replacement, which there's not too many programs that are doing this. And for Northern Arizona, I think it shows you the advancement and the perseverance and the passion that we have here to open it. So we've been very excited about our cardiology program. This has kind of been our general history since I've started. This is our hybrid procedure room. This is one of our other cath labs. Our electrophysiological studies are done there. Our structural program is done there. They look very similar, but they have a lot of distinct differences. I think John Amos touched on, we're proud to say we're going to open up a fourth lab, interventional lab, this week. And that has probably the most advanced and state-of-the-art equipment for imaging and structural heart disease as well as for regular interventions. And I think this sums it up as far as who and how and why we're here. And everybody has a strong passion for this program. I think everybody who's participated in it, they have their vision, they've combined that vision together, and I think they've not put their position in the way. And I think this is why we've been very successful. And to expand on that, I think our visions have been science and service. You know, we want to put what's best for the patient as far as science and technology, but you can't do that alone. I mean, you can have the best technology in the world, but if you can't deliver it with compassion, without compassion, and without care for the patient, and putting the patient's best interest first, then that program, no matter how good the technology is, does not get you too far. We've worked on this, and I think all our staff, anywhere from administrators down to allied staff, has this passion to help our patients. And as I said earlier, we want to keep our family here. You all, the patients in Prescott, are our family. Who better can take care of them but ourselves? And I think this has been an impetus to keep us growing new procedures and programs for our patients in Prescott. And of course, to keep always striving to keep a higher level and state of art. And I think we've done that. We think we've showed that with our new labs coming, our procedures, our imaging. But again, finally, we want to become a destination program. We want to be that program that serves and is a one-stop for all. I think not only cardiology, I think we want to expand that to other specialties and fields. I think our blood patient management program is already a destination program. I think Dr. Tibi has expanded this, has matured it, where we have patients coming up from Phoenix, from surrounding areas, and we also want to expand this to our structural program, to our electrophysiological program. I think we're really one of the only programs in northern Arizona that does do structural, and we want to draw on that. We want people to come to us, but we want to do this right, and I think we've continued to do so. Success of this program has, I think, 4 facets to it: teamwork, commitment, dedication, and passion. And I think I've touched on that with all our physicians, all our administrators, all our allied staff. It takes a lot of hard work, it takes a lot of passion, it takes perseverance. And I think we were blessed to have such a team that we have throughout the years. We have to have acknowledgments, though. I mean, there's people's names you hear more often than others, and some are here tonight. However, there's a lot of people behind the scenes that really are responsible for bringing this program to where we are now. And we need to thank our physicians, of course, our administrators, and past and present. I saw our former administrator here in the audience earlier, Tim Barnett, and from him to John Amos, to many of other administration, they've really been so supportive of physicians and are as excited as we are to continue to launch and advance our cardiology program. But really, who deserves the credit is really our patients. And this is our patients who have trusted us to take care of them, who has accepted our advancing in this technology. And, they're the brave ones. I think they really deserve more credit than we all do, because they've helped us want to do more for this program. And I'll leave you with this quote. I think I have a lot of quotes tonight for some reason, but I'll leave you with this quote. I mean, there's no medicine like hope, no incentive so great, and no tonic so powerful as expectation of something tomorrow. This is our mission. So we've seen our history, we've seen our vision. I think this is our mission. We have a lot of work to do still. So we're not over yet, no matter how far we've gotten and how much advanced equipment we have. It's not over. And we need to take what we've done today and do it better tomorrow. And this is what we are looking forward to providing for you. And I hope you enjoy the rest of the program. It's been a pleasure and honor being here. We have exciting speakers, and they will demonstrate to you what we have to offer. Thank you, and enjoy your evening tonight.
We as electrophysiologists are here to help find out the electrical inactivity or overactivity in the heart. The point of electrophysiology is to come and diagnose life-threatening arrhythmias or simple arrhythmias and find a way to manage them. To be very honest, I come from a family of heart disease and sudden cardiac death. So for me to be able to protect patients from sudden death means the most to me.
Ladies and gentlemen, please welcome to the stage Dr. Nisha Tung.
Thank you. Good evening to you all, and thank you so much for being here tonight. I'm Nisha Tung. I'm one of the electrophysiologists at YRMC. Some of you already know who I am. And I have a little presentation here, not too much. For people who want to know who an electrophysiologist is, I'm a specialist who deals with heart rhythm problems. So when you go in and see a primary care physician or a family medicine doctor, they refer you to a cardiologist, or they could refer you to a surgeon. We are specialists from cardiology standpoint. So you can see a heart plumber, that is the interventional cardiologist, or you see someone like myself if you have rhythm issues. So I'm the heart rhythm specialist or the heart electrician. So easy. I do deal a lot with atrial fibrillation. This is a major part of my practice. And as we get older, which is most of the population in Prescott, because we are a retiring community here, we see that the AFib increases as you get above 60, 65 years of age. People always ask me, what caused my AFib? And unfortunately, there could be a multitude of reasons for AFib or none at all. Age is a big factor. Sometimes, like I said, factors not yet identified. Alcohol, no, it's not a big factor. For some, right? You want to drink your 2 drinks or 3 drinks every night, it's just going to cause AFib down the road, unfortunately. Some people are prone to it because of genetic disorders. They have family history, hereditary. Others could be athletes here. We have a ton of people here that love to hike and go to the Grand Canyon. Excessive sports triathletes end up having a ton of AFib, unfortunately. We do have structural heart disease as a cause of AFib and hypertension, of course. People who are diabetic, there's so many reasons for people can go into AFib. So that's where you end up seeing me for that. Why does AFib matter? It's a very good question for everybody, because it can put you at risk of many other complications. The biggest concern is when you are having AFib, you can develop a blood clot. So you can have blood clots that can develop because your heart is irregular, and that blood clot can pool in the left atrial appendage, and that can break loose and cause a stroke. So a ton of patients are on blood thinners that they don't like to be on. They always come and ask me, can I come off of these medications soon? These blood clots do develop in what is called an appendage in the left atrium. Exactly how it's called, it is an appendage because it is an outpouching structure that should not be there. And we do end up closing that in some patients. If the blood clot was to break loose from that appendage, it can escape and travel to the brain, and that's how the stroke happens. Some patients can go into congestive heart failure just because of atrial fibrillation, because the heart is racing so fast. And if it goes on for a long time that the heart is racing, it can make the heart weak, and people end up having congestive heart failure. So what are the goals of treatment when somebody comes in with AFib? Number one, of course, we diagnose it. That normally happens either in the emergency room or your primary care physician, or you go for any kind of surgery like a gallbladder surgery, and they say, oh goodness, you are in AFib. It starts a whole series of testing. So once you're diagnosed, you want to reduce the risk of stroke, and there are some drugs that we give called oral anticoagulants, like warfarin or apixaban or Xarelto or Pradaxa. Or for patients who cannot be on blood thinners, we put in a device closure called as left atrial appendage closure device. That is just reducing the risk of stroke. How do you manage AFib? Is with either medications, and we always tell patients you're on a rate control medicine, it's just slowing your heart rate down, or I can put you on a medicine that can control your rhythm, meaning keep you in normal rhythm. So those are rhythm medicines, or sometimes I do procedures called AFib ablations, and of course, lifestyle changes, alcohol, smoking, diabetes control, hypertension control, all that comes into play. This is most patients' understanding of atrial fibrillation. You're at the crossroads, you have no idea what you're going to get done. And sometimes physicians don't know. When you come to me, you have to look at a whole picture, not just one little thing that you have AFib, and figure out what is the best treatment for you. So this is just the left upper chamber. This is the troublemaker for patients who go into AFib. It's a pretty complex disease. It originates, so if you can see, this is the chamber, the left atrium. These are pulmonary veins that are coming from the lungs into the heart, bringing the nice oxygenated blood, but they are the triggers of AFib in most patients. So what I do is I go in and fix that. So when I'm looking at patients, I'm looking at what is the trigger, what is the substrate for a patient with atrial fibrillation. Because we want to catch you at the trigger initiation, that is where the pulmonary veins are firing before it gets to the substrate, meaning that the whole chamber is the source of AFib, because then the success rate of the procedure goes down. Another thing really quick about this is we label atrial fibrillation as paroxysmal, comes and goes. Persistent, it lasts for days at end. Some patients may need to get cardioverted in the emergency room because they are in it. And then permanent is when you're in it the whole time. So you want to fix the problem in the initial stages rather than getting to the very end of that. Anybody has anything to say? This is how AFib is done. Well, this was in the old times, okay? Times have changed now. So this is where I perform my procedures. YRMC has been great in making this beautiful procedure room. It's called the hybrid OR, and I work in this wonderful room to provide care to the patients that I take care of. And this is the amount of stuff that I look at when I'm doing the procedure. These are all my monitors that I'm looking at. Yeah, I have one eye on one side, and I'm cockeyed half the time because I'm looking at different directions, trying to make sure I have a good eye on everything. So I have a very trained team that works with me to do these procedures with me. So when you ever hear, if you have been my patient or you've heard about it, you've gone on Google or gone down to Phoenix or other places, and you've been told that there's two ways of doing ablation. One is called radio frequency, and one is called the cryoballoon technology. So what I use is the cryoballoon for pulmonary vein isolation. So what I do is, remember we talked about the substrate? We want to get to the trigger part where it is just the veins firing before the whole chamber becomes a source of AFib. So I put this little balloon, go into these pulmonary veins, and I freeze the signals that are causing the atrial fibrillation. It takes about 2 hours under anesthesia, 2 to 3 hours, an overnight stay in the hospital. The other things that I do, other than AFib ablations, I do multiple other procedures for other arrhythmias like SVT, flutter, PVCs, premature ventricular contraction. People who have ventricular tachycardia, we go and fix those. People who have some racing heart rates from an atrial arrhythmia or ventricular, like I said, we can take care of all of those. But AFib is the biggest one because it does cause multitude of other symptoms, so fixing that is the most important. When patients go into heart failure sometimes, or they have fast or slow heart rate, like I said, the decision making is not simple. Some patients may end up needing a pacemaker, some patients may end up needing a defibrillator. So this is a little tiny pacemaker with wires going into the heart. Patients always ask me, how do you put that in? And I tell them, if I have to tell you, I have to kill you, because this is my secret here. So defibrillators are just a little bit bigger than the pacemakers. They do prevent risk of sudden death for patients who are at risk of sudden death because of a weak heart muscle, because they've had a heart attack or congestive heart failure. I put in these devices also for patients. And the difference is the device is bigger. It not only paces the heart, but it shocks the heart and brings them back into normal rhythm. A ton of patients ask me, well, is it a combo device? Yes, combo meaning it works exactly like a pacemaker with additional function that it shocks the heart, so it's your built-in paramedic watching over you 24/7. God forbid there was to have a bad rhythm happen. Another thing I do is people who go into congestive heart failure, as an arrhythmia specialist, I put in what is called biventricular pacemakers versus defibrillators. So they have the 3 wires. So Mercedes-Benz or whatever you want to nowadays, I don't know, what is the best car out there? Tesla? So that's the big device that we put in because it is helping with congestive heart failure management. It works like a pacemaker and a defibrillator. The other thing I do as an arrhythmia specialist is I want to prevent risk of stroke in the setting of atrial fibrillation. So there are patients who are put on blood thinners, and there are others that we have to decide about closing that appendage where the clots are forming. So we put in the devices called left atrial appendage closure devices to close that. So as a specialist, this is another thing I take care of. And this is what the device, it takes about an hour, hour and a half under anesthesia with an overnight stay, and we do them in the operating room again in that special room. And it goes, everything that I do goes from the groin for ablations, for devices, a tiny incision, which is about 3 inches long right here, 3 centimeters, I'm sorry. And that's all it is. It's minimally invasive procedures, but I do them under anesthesia so that you're comfortable and you're not talking to me. I don't like patients talking to me when I'm doing procedures. So that's my little talk. So thank you so much, and thank you for being here.
So the value of using minimally invasive technology like the transcatheter therapies that are available, one of the major benefits is the estimated blood loss, or the EBL, is significantly reduced. So based on the different therapies, the EBL could be 10 cc's all the way to maybe 30 cc's, which is literally a NyQuil cup of blood. So it's very minimal. So especially people that are very conscious about how much blood they're going to be losing, it is a really nice thing to be aware of.
There are patients who already are coming at a disadvantage with low blood counts to begin with, and these technologies will avail them of very, very minimally invasive catheter-based, where practically you can have less than 10 cc of blood loss.
Ladies and gentlemen, please welcome to the stage Dr. Sindos Muwala and Gwen Rhodes.
Good evening, everybody. Thank you so much. First of all, we are very grateful for this opportunity to be able to share our passion with you, and we appreciate all your time and all the teamwork to make this event happen. And I know you guys often see us together. We are called the Popsy Twins, Arnold Schwarzenegger, Danny DeVito, all sorts of combination, but we are just two faces of a big team. And that's something I really, really would like everybody to get across. The heart team is truly a group of people. Each and every one plays a role to make sure the patients are getting the appropriate care, the most appropriate procedure, and followed appropriately. So our portion is we would like to share with you the role of structural heart disease with relation to the blood management for patients. Gwen, anything else?
I agree 100%. It is really a very cool thing, the heart team approach. It involves all the surgeons, nurses, doctors, the OR team, the cath lab team. Everyone really works together to provide the very best plan for each individual person. So my plan would be different than like Dr. Muwala's plan. So it's a really cool thing because everyone really has the objective to get that person home, back in their life as soon as possible.
So I'm sure you've seen this slide before, and what I like about this is the fact that it truly shows the component of the integrative work that it takes to make the best decision for the patient. So there are some stuff related, how do we optimize patients' blood thinning strategies? How do we manage the patients when they are anemic? What do we do? What are the options for these patients? But ultimately, why is that important? Because that's been shown to actually shows improved patient outcome. So it's not just a slogan, it is truly an approach. I know we are a little bit simplistic. We talk to a variety of patients with various ages, different educational background, and we usually try to break it down to the basics that the patient needs to understand what's going on. So often the analogy that Gwen and I share with these patients, the house is like the heart is like a house. You've got the doors, which are the valves. That's some of what we do in the structural team. You've got the muscle, which are the walls. You've got the electricity, what Dr. Tong talked about, the electrical wiring of the heart. And then you've got the plumbing, which is the coronary arteries that feed the heart. I'm by training a plumber and a structural, which means a carpenter. So the carpenter, which is like the valves, the plumbing, and like Dr. Tong would be the electrician, that kind of thing. And so it's just to, for the people, I don't mean to insult the people who have more medical background, but just to give you an idea. So the structural heart truly involves every aspect of these elements that we just talked about. And so let's just start with what Dr. Risk had alluded earlier, the program that started here in 2016, which is the TAVR, the transcatheter aortic valve replacement. And it's actually a misnomer. It should be an implantation, TAVI, because we're truly implanting a valve. We're not removing or replacing the old valve. We're just implementing a new valve that functions instead of the old valve. This is a minimally invasive procedure that is catheter-based. In 95% of the time, the catheter is advanced into the body via the femoral artery. There are some other approaches through some other arteries, the subclavian up in the chest, sometimes the carotid, sometimes the aorta itself, and sometimes from the apex of the heart. That decision is usually a cumulative decision that comes between the interventional cardiologist, the imager, anesthesiologist, the cardiothoracic surgeons, who play a very, very big role. In this topic specifically, I really would like to give a huge tribute to Dr. Tibi and his team, because they've been absolutely instrumental in bringing the technology to Prescott. So the second technology that focuses on the mitral valve. It's one of the available technologies. It's actually technically right now the only FDA-approved technology in the United States. It is called the mitral clip, which is a small device that's delivered by catheters through the vein from one chamber of the heart to the other, and try to get the leaflets of the mitral valve closer together to reduce the leakage. This is for patients who have leakage in their mitral valve and they are not candidate for open heart procedures to repair the valve or replace the valve. And that decision as well is made globally with the surgeons. So we decide with Dr. Tibi, Dr. Torres, and Dr. Ataran as to, is this patient better served with the minimally invasive procedure versus a open heart procedure where the valve is repaired or replaced. And there are various factors that goes into that. So the next one is the paravalvular leak. I'm gonna let Gwen talk a little bit about that. Go ahead.
Okay. So when we put a new valve in where the old valve is and push the old valve out of the way, lock it into place, every once in a while, because it's so chunky and crunchy, you end up with a little gap between the heart tissue and where that valve is. So the blood's flowing along the outside of the valve instead of through the valve, which is how we want it. So sometimes this makes a person very symptomatic. They become very short of breath. They're having all the same symptoms that they had with heart disease beforehand. So they can actually go in through the same spot that we went in for the TAVR, or even if they've had open heart, and we can go basically and put a little plug in that spot so that they're not having that paravalvular leak anymore, and it takes care of their symptoms. And so now they're right back to having a nice, pretty valve that's working and functioning the way it's supposed to.
And that spares the patient a second open heart surgery. Yeah. So this is a very, very important concept. So the other segment where structural heart plays a huge role is the role in stroke prevention. Strokes are complete, even though the thought of it is neurological, really 90% of the sources of strokes come from the heart or cardiovascular system. And the structural program is very instrumental in trying to have stroke strategies. Dr. Tung spoke about one of them as well, with the left atrial appendage occlusion, and it is the procedure where we actually occlude the appendage with a Watchman device, and there are other devices that probably will come on the market. In addition to that, the PFO closure, there are patients who have birth defects that are born with these holes, and over time there are certain risk factors that they can form a clot here and send it to the brain and have a stroke. So we just would like to show you a couple of the pictures where this is a device that's the PFO device that straddles both sides of the heart, the right and the left, to plug that hole. It's delivered via a catheter. It usually takes about 10 minutes to do, and basically the patients have to be on blood thinners for several months, and subsequently thereafter they have to remain on aspirin. I just want to draw to your attention that 25 years ago people needed to have this surgically repaired and had open heart surgery that's far more invasive, far more chance for blood loss compared to a 10-minute catheter procedure. This is the picture that was shown earlier as well by Dr. Tung, the Watchman device, which is a catheter device that looks like a strawberry that has a mesh on it and basically plugs that area, which is like a lagoon where the blood tend to aggregate and clot and can go to the brain and cause a stroke. One of the things that I want to emphasize, and it is truly meant, when I say the word the team, it's truly a team. And it doesn't involve one person cannot do it. And probably this is one of the most, I would say, instrumental development in the care of patient over the last 10 years, because historically there was a drift always between the surgeons and the cardiologists, and difference of opinion and fighting for territory, which really didn't serve the patients well, because the goal is you want to deliver the best strategy as a team that you think it's the best strategy. And the cardiologists learned that from the oncologist. The oncologists came up with the tumor board, where it involves the oncologists and the surgeons and radiologists and various other disciplines to decide what is the best approach to patient care. And then subsequently the transplant team picked after that, and then subsequently finally the cardiologists and surgeons decided 20 years later we're going to come up with a heart team. But thank God the bulb, came on. So it is really one of the best development that ever happened in the medical arena from a cardiac care. And it really involves the cardiothoracic surgeon. Dr. Tibi, Dr. Torres, and Dr. Ataran have been wonderful, and needless to say, the steps and the work that Dr. Tibi has done over the last 12 years has been absolutely amazing, and the team building that he constantly encourages is absolutely phenomenal. The interventional cardiologist, myself, and there is a wonderful other team. We'll show you some of the pictures. I want to draw attention to the advanced imaging. Dr. Risk is one of the huge members of this team. We also were fortunate to draw a national figure who comes and helps us in Prescott, Dr. George Gellert. He joined us last year, world-renowned imager. Truly, without him, there are certain procedures we would not have been able to do here in Prescott. The CT imaging, Dr. Kumar and the radiology division, the anesthesiologists have been absolutely tremendous. And even though I put in the structural coordinator right at the bottom, it's actually right, it is the base. It is truly the base. And I put her picture right in the center because I see Gwen as the glue to this team. It truly is. And these are only the physicians as part of the team. And yet, I'm so pleased today to see our members of the cath lab staff. We have Miss Lauren Whedon. Please, Lauren, stand up. up. She is the director of our cath lab and has been absolutely phenomenal. Truly phenomenal in building a phenomenal team of techs and nurses in the cath lab, and has worked tirelessly over the last 2-3 years. We are going to be opening a new state-of-the-art, new 4th cath lab here in Prescott. The technology that exists is the first of its kind in southwestern United States. I want to re-emphasize that. The first of its kind. And it will be a showcase for multiple other people to come and learn how to do these procedures with these technologies. And that is a huge segment. Without these people, we can't do these procedures. We can sit and talk about them, nothing's gonna happen. Then there is another team, and I really wanna compliment Diane, Ms. Dexter Priest, and she's the Chief Nursing Officer for our hospital and has done tremendous job in building the nursing community that allows us to also take care of these patients. You know, we do procedures and we come here, but the nurses are taking care of these patients. So Diane, thank you so much. One last thing I would like to draw as well, and this is really a tribute to Dr. Tibi. Over the last year, and this tells you about his vision and how remarkable this gentleman is. He found that this is very important. We are a small community, yes, but we have a lot of pathology, a lot of retirees, and we are also a little bit isolated geographically, and the location and the elevation and so forth. And he realized the importance of bringing research into YRMC, and that will allow us to avail patients of newer technology that's only available in academic medical center. And we have also Ms. Lynn Bassett, who is the director of our research. They already started 2 clinical trials here, and we are looking for more. And I hope you guys can just see a little bit of the wonderful, I'm very proud. I'm truly, truly proud to be a member of this team, to be able to serve this community, provide the best care. And I'm not saying this with arrogance remotely, but truly we are providing care that's only available in academic medical center. And you as a patient are supportive of that. And we are very grateful for that. And it gives us the opportunity to grow and be a destination center for all Northwestern Arizona and some of the areas that doesn't have these services. We are the only small community hospital in the state that offers any of these technologies. Thank you again for your attention. And Gwen, final word to the Queen.
Well, the one thing I wanted to really emphasize to everyone, so Dr. Tibi, of course, brought the patient blood management, and I think that's why a lot of us are here tonight, because we're very interested in blood conservation and providing good care to the patients. And you as patients want to hear that we can take care of you without blood products or minimal blood products. So the fact that not only is there open heart surgery where Dr. Tibi utilizes these different blood saving techniques to provide excellent care to you without blood products, but because of the structural heart program that is now here, like you were seeing on the vignette earlier, the average blood loss is very, very low. And so a lot of these patients, a lot of you get to go home the next day and with minimal recovery from any sort of wound or incision. So it's very nice thing to have here in the community, and we're a very unique place actually in Arizona and actually in the whole southwest part of the country that we can provide these services for you and be able to take care of you while honoring your wishes.
And one last thing, I want to also thank the administration in our hospital. So if you look at the amount of investment that went into this hospital in the James Family Heart Center over the last 12 years, and a lot of capital over the last 5 years, we really have to give our hat to the administration to take the risk and put the investment, and we are very pleased that we actually see the reward, that we're providing care, but also without a positive administration, none of that would be possible. So when I say it's a team, it truly is, and any missing puzzle of that, the process will fail. So we are proud to be part of this, and we are grateful to have this opportunity to present to you, and thank you so much for your time.
Thank you.
At YRMC, we've seen red blood cell transfusions reduced by 33% in 2018, and fresh frozen plasma transfusions have been reduced by 63%. And this is good, because when patients can avoid unnecessary exposure to those risks and complications that come with blood transfusion, they're going to have better outcomes. Reduced hospital length of stay, reduced infections, morbidity, and mortality. So improved patient outcomes is what it's all about. At YRMC, we have a dedicated team of medical professionals, administrators, and then in the community, we work with people that appreciate the efforts that YRMC is making to provide better care. Not only when you're a patient, but the patient's family appreciates that too, and they have a better quality of life. And so it's nice to work with something that matters to help people maybe in their greatest time of need.
Ladies and gentlemen, we are pleased to welcome back to the stage Elizabeth Black.
I wanted to share this. I found it on the internet. Now, we could say with a high degree of certainty that this Scottish knight and hero of the 13th century did not say this. First of all, the idea of collecting, analyzing, interpreting masses of numerical data, statistics, didn't appear to come into use for a few hundred years after this. But I thought it perfectly captured a couple truths. One, you already know, you can't trust everything you read on the internet. But two, looking at the actual message, statistics can be used to convey an idea that may not have any connection to what you're really measuring, or as we see in this case, to reality for that matter. So while it's true that we must be careful when looking at statistics, and that numbers don't necessarily tell us everything, they can tell us some useful things. This is true in the field of medicine too. For example, Freedom magazine out of Charleston, West Virginia, reported that in West Virginia between 2007 and 2012, distributors sent more than 780 million hydrocodone and oxycodone pills into the state. And even though 1,700 deaths due to fatal overdoses from those two drugs were also reported, the flood of pills continued. One town of 400 residents was sent 9 million opioid pills in 2 years. That's 937 pills per month per person for 2 years. Now that should have been telling somebody something, right? Well, when we see a drug or a treatment that is prescribed very frequently, we rightly ask, is this the right treatment in the right amount, at the right time, and for the right patient? So what about blood transfusions? Well, published studies show that less than a decade ago, in 2010, blood transfusion was the most common procedure performed during hospitalizations in the US. 1 in 10 patients undergoing an invasive procedure received a transfusion. Were all those transfusions really necessary? Well, in July of 2011, the journal Transfusion Medicine published findings of a panel that systematically reviewed transfusion appropriateness. Appropriateness being defined as the likelihood of improving health outcomes versus hurting them. And in that study, 59% of red blood cell transfusions were deemed inappropriate. 27%, it was uncertain whether the benefits outweighed the risks, and only 12% were deemed appropriate. Does that indicate possible overuse? So certainly in 2012, the timing was perfect for YRMC to begin developing a patient blood management program. The goal was to promote improved patient outcomes with a focus on caring for what could be called the patient's liquid organ. Well, how would this be accomplished? At the outset, it would begin by applying the most recent medical research that was pouring in about the complexities and risks of blood transfusion, the cost of it to healthcare, the cost to society. As clinical information was shared with medical staff and community physicians, logically we would anticipate that we'd see different approaches to be utilized in caring for a patient's blood health. And we'd expect to see a reduction in the use of blood transfusions as that go-to treatment. So we began to chart the behavioral changes in transfusion that we were seeing. Now, of course, to know where you're going, you have to know where you are and where you've been. So we developed a 4-year baseline of blood product utilization pre-PBM program. That was from 2008 to 2011. So that's this first column. And we've been tracking transfusion practices in the years since blood management has been established at YRMC. And I know that's a little bit hard to see, but we wanted to share some of the encouraging results. As of the end of last year, and we're right on track for further reduction this year, red blood cell transfusions, RBC transfusions, had decreased by 33%. Now, when we're dealing with larger numbers, sometimes this kind of a decrease is a bit harder to appreciate. So I thought maybe we could illustrate it this way. Imagine if instead of spending $150 on your groceries, you only had to spend $100, thereby saving 33%. Well, that would make a difference, wouldn't it? Because the next time you go shopping and you're going to spend $100, you already have half of the resources that you need for that trip. Well, what this means in terms of blood management is that patients are exposed less frequently to the risks associated with blood transfusion, and more importantly, that other strategies to build blood health are being employed. So how has this reduction in blood transfusion been achieved? Primarily, it's by understanding that reducing transfusion is not the goal. It's just a byproduct. PBM is about embracing current scientific and medical research, combining evidence-based medicine with good clinical practice. And PBM is rapidly becoming mainstream medicine rather than being about finding alternative treatments to transfusion. Now, as this shift occurred, a key behavioral change has been the adoption of a more restrictive strategy when it comes to RBC or red blood cell transfusion, rather than a liberal one. Whereas doctors believed for decades that if a patient's hemoglobin dropped to 10 grams per deciliter, he or she required a transfusion. Current data shows that in a hemodynamically stable and non-bleeding patient, that a hemoglobin of 7 can actually be tolerated. And so we've seen in this area a dramatic drop too, 42% of transfusions that occur above that 7. Many times that's because they are a bleeding patient. Now, another area of intense focus has been in the use of fresh frozen plasma, another major component. In 2018, going back to that slide, we had seen a decrease in fresh frozen plasma of 63%. So if we look at our grocery illustration again, that would mean that if you were shopping, instead of spending $100, you could get those groceries for $37. That's a big decrease, right? And of course, in order to do that, you'd have to travel back in time to 1982. But we're not focusing on money savings here, but it just helps us appreciate that, again, when patients do not receive unnecessary treatment and potential exposure to increased risks, this is a win. Physicians are learning other safer ways to manage coagulation issues in patients with bleeding or bleeding potential. Now, as you can imagine, these kinds of decreases, they really reflect changes in individual physician transfusion practices. So we wanted to show you some of the changes, just kind of in a sampling, and you can't read it anyways. We actually changed the names to protect the innocent, but you can see, you're seeing drops, right? Both in the use of RBCs, and then if we look at FFPs, the same thing. These are individual physicians and the changes that have happened in these last few years. It's not always linear, but we definitely can see that patient blood management principles are being adopted. Well, and one point we want to make, so we're seeing these reductions, but all the while, YRMC is treating a growing population in the area. They're treating more complex cases and an increased number of surgical and interventional procedures. Now, are you more conscious of your speed when you're driving and you see one of those speed limit signs where it shows, your radar speed? I know I am. And it turns out maybe as many as 80% of drivers are actually impacted by that reminder. Well, so too in increased PBM education, clinical decision-making support, along with tracking and sharing utilization reports with physicians and regularly reviewing transfusion appropriateness, these are just some of the effective measures that have yielded great results at YRMC. You might appreciate by now that we're pleased with the achievements of patient blood management, but we still have future goals for key areas where we know additional progress can and will be made. And we'll continue to work together to reach those goals. And we say together because, as Dr. William Mayo of the late 1800s noted, the best interest of the patient is the only interest to be considered. And in order that the sick may have the benefit of advancing knowledge, union of forces is necessary. So with PBM, it's more like being on a baseball team than being a figure skater. In fact, we could say it takes a Yavapai village to achieve good results in implementing patient blood management. Hospital and community physicians, surgeons, nurses, hospital administrators, and a wide range of clinical and non-clinical staff. As you saw in the lobby, device manufacturers and pharmaceuticals, they've greatly added to the PBM toolkit that improves patient outcomes. And then there's you, the community, and the role that you have played in striving to make sure that the best care is obtained. You're educating yourself about this important area of medicine. You're realizing the importance of knowing your blood numbers, recognizing symptoms of anemia, beyond cravings for dirt and paper, which probably would prompt a call to the doctor. You're also talking with your surgeon several weeks before you have a surgery or a procedure, an elective one. You're talking about optimizing your blood stores and treating even mild anemia before a planned procedure. You're also learning about the many means of minimizing blood loss during procedures and making sure that these are part of your care. And then during hospitalizations, you're alert to reiterate your wishes that phlebotomy or blood draws are limited to only what is clinically necessary. Remember, KTB, ITP, keep the blood in the patient. So when we reflect back through history, bloodletting was broadly practiced for thousands of years. Transfusions for decades. But we live in a time when leaders in medicine are continuing to develop strategies to keep your blood in you and to keep it working properly. And these really are kind of heroic measures. So while the hero and knight, William Wallace, may not have made any famous statements that were connected to the stomach, he is remembered through this lovely monument in Scotland, and it's a tribute to his brave heart. But here in Prescott, we appreciate the efforts of our local heroes as they continue to provide better ways to manage our blood and bravely help us maintain healthier hearts. Thank you.
YRMC is the destination program for both cardiac care and patient blood management. 12 years ago, neither existed here in Prescott. With the development of PBM and cardiac care, including cardiac surgery and structural heart, we have not only married those two programs together, but we've advanced them to the point where we are now a destination program for both those facilities throughout the Southwest.
Ladies and gentlemen, please welcome to the stage Dr. Pierre Tibi.
Hi there, everybody. You know, I just got out of work, seriously. I didn't even know I'd be here. It was a stressful day, and I had a suit and a tie and everything, so I apologize. I'm going to go back as soon as this is done, so please forgive my appearance. But I do look more surgical-like here. So, you've heard some wonderful talks today. And what we're doing at YRMC. And I want to show you how I believe that YRMC is advancing to the next level, to the beyond. So my hypothesis, and I think it's more than a hypothesis, is that YRMC is going to be and already is a destination program for patient blood management and cardiac care. And if I'm going to prove this, I have to first go through the definitions. Now, you've heard tonight about cardiac care and all of the wonderful things that the cardiologists and the interventionalists and the electrophysiologists offer here. And I can tell you, if you look around, there's no other community hospital around Arizona and around many places around the United States that offer what we do here. So I beg to differ that we are not a community hospital anymore. We're a destination program. And a destination program, so you know about cardiac care and what is patient blood management and what exactly is a destination program. So let me go through some definitions. So patient blood management has been defined over the last decade or so in multiple ways. But if you look at each and every one of the definitions, and some of them by Society for Blood Management, some of them by the World Health Organization, some of them by the United Kingdom Blood Transfusion Services, some of them by the AABB, or the American Association of Blood Bank. And if you can read that, I don't know if you can read that, but if you can read that, you can see that these definitions, all four of these definitions, talk about blood transfusion. This one in SABM is avoid the need for blood transfusion. The one from WHO, the safe and rational use of blood and blood products. The one from AABB, transfusion decision-making process. Each one of these definitions is blood-centered. It's mainly focused on thresholds. If your blood count is low, then you need blood. It relies on transfusion and transfusion of blood and blood products. So this is one type of definition. Most recently, us at the Society for the Advancement of Blood Management came up with a new definition, and I want to read this definition. The definition states that patient blood management is a patient-centered approach, comprehensive approach to blood homeostasis that first and foremost aims to improve the patient outcomes. It involves the timely, multidisciplinary application of evidence-based medical and surgical concepts designed to maintain blood homeostasis. Patient blood management requires a global institutional approach that ensures continuity of patient care and includes, but is not limited to, increasing pre-procedural red cell mass, meaning how much blood you come in if you're going to have a procedure, minimizing blood losses throughout the care episode, that's pretty obvious, and improving patient tolerance to anemia. Nowhere here does it talk about blood transfusion. And why is this important? Well, it's important because this is how I feel that patient blood management is addressed at Yavapai Regional Center. We're not talking about blood transfusions or giving products or not giving products. We're talking about taking care of the entire patient and making that patient as safe as possible before, during, and after that procedure. And one of the things in making someone as safe as possible is not subjecting them to a possibly unnecessary transfusion, because you've heard about the risks of transfusion. So you might say, well, this is just semantics, right? But it's not. It takes into account frame of reference. And I think one of my son's teachers out here, and my son taught me about frame of reference. He's in 6th grade. And the problem, he comes home with a problem and he says, Dad, we're learning about frame of reference, and if somebody throws a ball up, is on a train, leans out the window and throws a ball up in the air and catches it, how far does that ball travel? Well, for the person on the train, it goes up and down, that train is moving. But if someone is standing outside the train, when the person throws the ball up, it goes up in an arc and travels at the rate of the train. So it's all about frame of reference, and that's why it's important. When you have frame of reference, then you know best how to treat patients. And if your frame of reference is blood transfusion and no blood transfusion, okay, so if you've got to, if you're pretty good with understanding that you don't have to transfuse somebody to a hemoglobin of 10, then fine. But if you're taking care of the whole patient, if that's your frame of reference, you're doing everything much better. So that's my definition of patient blood management. Let's go through a definition of destination. What is a destination? A destination is a place to which one is journeying or to which something is sent. And therefore, a destination program is a place with a program in place to which one journeys to, or where one from that program is sent to educate. So I told you that I think that YRMC has become a destination program. So patient, and you've heard about all of the cardiac care that we offer that is really not available in too many places. Let me tell you about the patient blood management program that we have here. We've had it since 2007. And I was involved with patient blood management before I came to Prescott in Phoenix. But when I came here, we started patient blood management just for cardiac surgery, and it's taken over the entire hospital. Well, why is patient blood management important? Well, it's important globally throughout the world. And how do I say that? Why do I say that? Well, in the United States, what's very interesting is in the United States and in Europe, patient blood management is there for quality and for economics. It saves money if you don't have to give blood. Obviously, if you don't have to give blood, you don't subject somebody to a foreign transfusion. But in China, with its one-child policy and upside-down triangle population, meaning there are very few young people and many older people, it's more a matter of lack of resources. There is not enough blood in China to be able to go to all that needed. In addition, in third world countries, it's not so much a lack of resource, it's not so much about quality or economics, but 80 to 90% of the blood is tainted in underdeveloped countries. So back when I first started here, I happened to be called to present to China, and I've been to China several times, like I said, because they just have so much blood shortage that patient blood management is extremely important to them. Advanced medicine, which minimizes the need for transfusion, may be the answer to the mainland's chronic blood shortage. And this is where we presented. And shortly after that, I got a call from Vice Minister of Health Services from China. And they said that he was on the phone, and he told me, he goes, I have almost all of my chiefs and vice chief of anesthesia coming to San Diego for an anesthesia meeting, and would really like to visit your institution. Now, I had been to China numerous times. In China, the hospitals have 7,000 to 8,000 beds. And I said, and thinking about that, and thinking about them coming to here, and I said, I guess I must say I was a little embarrassed that we kind of had a small hospital. And I said, well, you don't understand, San Diego is very far away from Prescott. You wouldn't want to make the trip. And they go, no, we know we have to take a plane. I'm like, oh, no, but you have to take a plane, and then you have to take a 2-hour bus ride, which is very uncomfortable. And they said, no, we know, we want to come. So I said, okay, so I talked to the people and asked Tim Barnett and said, hey, why don't we put together a symposium for these people from China? And we did. We put together a closed circuit TV. We had docs who gave a half-day symposium. They were all in multiple rooms throughout the hospital. And then we did a live presentation of a reoperation on an open heart patient who refused to have blood. And everything went very well, but they really, I think, liked going downtown, going to Whiskey Row, going to the Palace, meeting the painted ladies and the gunslingers, and being able to hold a gun. And after about here they've all had their drinks and so forth. And I said, what do you think the best part of your trip to America has been? And I was hoping they'd say, oh, this is great. They said, oh, we haven't come to that yet. I'm like, what? They go, we're going to Disneyland tomorrow. Swear to God. So going through, we've been out to the YRMC Patient Blood Management Program has been talked about in Nigeria. We were invited to go to the University of Calabar in Nigeria, which is the largest university hospital in Nigeria. That was the program. I was fortunate to be in attendance of the opening of the first bloodless medicine and surgery program there in Nigeria. And this is Dr. Nathaniel Usoro, who's been a strong proponent of patient blood management, brought that to Nigeria, but felt that he needed some experience from the States to bring it to Nigeria. Also, South America, one of our own, we presented in South America, myself and you know, some of these names probably at the hospital, Jeff, Jose Torres, Jared Head, etc. We put together studies on patient blood management, which we presented. That was in Cartagena, very nice place. Most recently, just a couple of months ago, we were asked to go to Brazil, to the INCOR Hospital in Sao Paulo, Brazil, which is the largest open heart center in South America. And myself and another woman that's on the Society of SABM also presented. And I just took these pictures because if you're interested to see what universal healthcare looks like, that's how it looks. This is at 6 o'clock in the morning. People are lining up outside the hospital, waiting to be seen by a doctor, any doctor, in hope that they get in. You know, and I'm not going against universal healthcare or for universal healthcare. This is not a political talk, but there are ways to do it so that it doesn't look like this. So I think I've shown that, you know, we take our patient blood management program, we bring people to it. We've gone, you know, we've brought people from all over the states to it to look at it, and we bring people from the Southwest. I think I hope I have convinced you that Yavapai Regional Medical Center is a destination program for cardiac care and patient blood management. Thank you very much. So at this point, I'd like to bring out our panel. And the first person I'd like to bring out is Dale Black, and many of you know him. Dale Black is the reason with Beth for this patient blood management program. He's been fastidiously working and making this program at YRMC known, at least nationally, as one of the best patient blood management program. And you've met Beth Black, Dr. Nisha Tung, Dr. George Risk, Dr. Sundos Moala, and Gwen, my favorite. And so we're going to go to a question and answer period, and I think Dale has accumulated questions, and I'm going to sit down because I'm tired. Has accumulated questions both from staff, from people who have attended this conference before, and he's put them down for, I'm going to talk about or ask these questions to our various members. The first question, it's what really motivates YRMC to support these unique programs as such as the extensive cardiac care and patient blood management program? I'll start off by answering, and then anybody else can chime in. You know, I've been here 12, 13 years, and I wasn't necessarily excited to come to Prescott, I got to tell you. When actually Tim Barnett said, you know, we'd like you to come to Prescott, and I'm like, well, you know, I've been in a big city my whole life, etc. And I said, but it's not going to work. You know, you're a small community hospital, and you know, I'm down at Good Sam, and we've got research, we've got this, we've got that. And he goes, we will have the best open heart program that you can make. And I believed him, and I still believe him. I still believe John Amos and the administration here. I really do think that done everything they can for a community of this size to offer more and more than any other hospital in a community this size, or even a community much larger than this. We have the expertise and the machinery and the innovations that rival many places in large cities. So, obviously we don't do transplants, we don't do ventricular assist devices, so because that would need a fair amount more, but like I said, this administration and this hospital and this community has supported the excellence in cardiac care and patient blood management. So that's what I...
Geez, Peter, I painted a whole different picture to the audience before you got here. You told me you couldn't wait to get up here. I mean, I also said you were my best friend and my best colleague.
That too. Would anybody else like to comment?
Actually, I would like to add just to that, Dr. Tibi, thank you so much. And actually, that's probably the beauty of the place in so many ways, because I've been mainly only of big systems. I am not aware of anything but the big system. And the inertia of the big systems become very big to a point sometimes very difficult to get anything done. And that's probably what makes this place so unique.
I agree. So our next question was, this question from someone stated, when I have already signed the necessary consents expressing my wishes pertaining to blood products, why would the surgeon or anesthesiologist ask me the day of my procedure again about my choices? Gwen Rhodes, can you answer that?
Yes. So I think it's important for people to know, because I actually have a lot of people ask me this, because then they feel like they're being pressured. Why does everyone keep doing this? They're trying to pressure me. They're trying to get me to do things. But it's actually the physician's responsibility to hear it from your own mouth how you're feeling about the treatment you're getting. So the anesthesiologist might have just been assigned to your case, maybe the night before, whatever. He has to hear it from you, even though you have a blood band on, even though you've signed, I don't want blood. He needs to hear it from your lips that is your decision for him to go on. And interestingly enough, this is actually true for pretty much all the consents in the hospital. So like for the TAVRs, when we do TAVRs, people agree to a different amount of aggressiveness in recovering them if in the event something goes wrong. So they tell Dr. Tibi or Dr. Torres or Dr. Adaran when they're talking about this procedure, but then the anesthesiologist comes in and says, is this true? Is this what you want? Could you please tell me what you want? So you have to tell the same story over and over and over going to every doctor who gets a consent from you. Every doctor who touches you during a procedure basically has to have a consent from you. And they all need to hear the same story from you. So that's why when you're in the hospital or if you're getting a procedure, you will have everyone who comes and talks to you and gets a consent will say, how do you feel about blood products? Do you want blood products? In the event that this happens, do you want blood products? Because they need to hear it from you so that they know how to follow your wishes, because you as the patient have the right to tell how you want to be treated, what you'll accept, what you will not accept. And so that's why everybody asks you that question. They're not trying to pressure you, they're just making sure that everybody's on the same page.
Thank you.
And they don't have dementia.
Right. Yeah, we want to make sure you're not crazy.
Dr. Riz, as a middle-aged adult in relatively strong health, at what age do you recommend that I consult with a cardiologist for a checkup? Or do I just wait until I am experiencing problems or symptoms?
And that's a good question. My best advice is stay away from doctors, really. Stay away from cardiologists especially. I mean, if you can avoid it, we'll ruin you. But in all honesty, that is a good question, because I think there's a lot of healthy people or a lot of asymptomatic people in the society and community that probably have underlying disease that's not known. So when is the best time? And I don't think there's any concrete age that we can give you. I think it really depends on, yes, if you are very active and asymptomatic, that's a good plus. But we've always kind of banked it on what your risk factor profile, what your risk assessment is for developing heart problems. And that's based on, usually 5 major risk factors. Genetics or family history is an important one, and smoking, high blood pressure, diabetes, and high cholesterol. So, you should, number one, you should be, if you're middle age, you should have already or should be establishing with your primary care physician. You should be having your yearly checkups, and you should include your labs for cholesterol, screening for diabetes. Of course, take into account if you do have family history, that kind of heightens our awareness of what to do next for you. And then, of course, many of the primaries will include an EKG when you get to a certain age, and I think that's very reasonable. I think one of the other big questions is, do we need to take it further than that? Do we need to do stress testing? Do we do high-level imaging and cardiac studies? And it's not advocated for everybody, no. But I think if you have increasing at least 2 or 3 risk factors, at one point, probably in your middle age, not necessarily you have to meet with a cardiologist unless if you're having symptoms, absolutely. But beyond the screening, EKG, and testing, they can order screening stress test, and that is one way. It's not the only way, and it is not 100% guarantee. But awareness, I think, is the number one thing that everybody should keep in mind based on what risk factors you have. Because the older we get, that is also another risk factor. It's almost like within time in the house, the pipes, after a certain number of years, the pipes clog, so do our arteries. And you don't, in some cases, there's some of our patients who don't even have risk factors. So be aware, and I don't think everybody has to see a cardiologist, but if you are a high-risk patient and we can establish that with certain tools that kind of calculate your risk, then I think we can take next steps for additional screening exam. I don't know if my colleagues have anything else to add to that.
What kind of symptoms, though, that are going to be very determinant for you to see somebody right away?
So we hear the traditional symptoms of chest pain, pressure, a tightness in the chest, elephant sitting on my chest. Traditionally, typically people read the textbooks or the internet and radiates to your arm, up to your neck. You sweat with it, you get shortness of breath. Sure, these are all extremely most common symptoms that we should be paying attention to. Could be more subtle too. Besides the classical presentation of chest pain and associated symptoms, it might just be shortness of breath. It might be fatigue, and there's so many causes of fatigue. I'm not saying if you have fatigue, you don't need to rush to see the cardiologist, but in addition to that, women is a different subset. Women present atypically, so you will not, in about 50% of women, you will not get the typical symptoms of chest pain, crushing feeling, tightness. I mean, you may get atypical chest pain, you may get shortness of breath. People think it's indigestion. They're commonly mistaken for that. So there is a difference between whether you're male and female, and everybody presents differently. I remember, and we all have had patients like this. One patient came in with a heart attack, and all the complaint was teeth pain. Your teeth hurt, and unusual. Very rare, and if your teeth hurt tonight, please don't rush up. See your dentist first, probably. But those are the typical symptoms.
Thank you,
But keep in mind, it is still the #1 killer in this country. 650,000 people die every year from cardiovascular disease. 50% men, 50% women. And it is more cumulatively than the next 7 causes of death to follow. So 1 in 5 women will die from that, and 1 in 4 men will die from that.
And more than that if you get blood transfusions.
What was that?
More than that if you get blood transfusions.
Oh yeah, for sure, for sure.
So, Dr. Moala, what is the connection between good cardiac care and patient blood management?
I think that's a dialogue that we always often talk about, that it is very, very under even given to healthcare professionals in terms of education from the beginning. And I think last year we talked about this. I personally, all through medical school, I don't know about everybody else, never ever had any talk about blood management. And that's shameful. And why? Because at least the three of us here probably prescribes more blood thinners than anybody else probably in, out of any specialty. So for me, from a cardiac point of view, good cardiac care, number one, understanding the disease pathology of the patient, what's the most appropriate blood thinners that we encounter for these patients. But then what are the risks with these blood thinners, and how do we manage that for the patient? And what are the alternatives to blood thinners if we can offer them to try to avail them of that? I see that hand in hand with blood management because it's one of the most common cause of ER visits. It's one of the major causes, meaning bleeding, why people will discontinue the blood thinner. I think that's one aspect we see. The other aspect is what we talked about earlier, which is how do we try to increase the implementation of minimally invasive procedure where the blood loss risk is much, much less, so the patient is at much less risk of needing any blood product. So that's how I see that relationship.
Thank you. Dr. Tung, what are the symptoms of anemia, and is anemia an issue in cardiac patients and/or electrophysiology?
Definitely. So the question is anemia with heart disease. Are patients more symptomatic with it, and what are the issues? Most patients who have cardiac disease, if they have low blood levels, they're going to be more symptomatic, more short of breath, more chest discomfort, decreased level of activity, cold, clammy feet, tired, fatigued all the time. So I had a patient just recently, I was going to put a Watchman device in. This is just one of the things we see. Patient came with a hemoglobin of 7, felt miserable, kept thinking it was his atrial fibrillation. And of course, we had it on the table, just one of those bad days when the labs don't show up and you say everything was fine just a month ago. Patient had dropped his blood level by 7 points, from 14 to 7 grams of hemoglobin. He felt horrible. And the biggest symptom he had was, I can barely do anything. I can't go throw my trash out. I can't take the trash can down. My wife gives me these chores to do, and I can't get anything done because I'm short of breath. So this is very common when people have low hemoglobin levels, that they feel really bad.
And if I can add to that, it's interesting because not uncommonly, they're sent to us. They're referred to cardiologists because these symptoms we just talked about, a lot of them are overlapping. Mm-hmm. They're short of breath. They get chest pain when they try to do something. They're so fatigued. And we almost start this cardiac workup, and we have to remember we've got to include labs if they haven't been done already, because there's a small minority you find out that are severely anemic rather than a cardiac problem.
Actually, if you look at the statistics, close to 60% of patients that come for cardiac surgery, elective cardiac surgery, have at least mild anemia, and 10 to 15% have severe anemia. And the biggest determinant of whether you will be treated with a transfusion after surgery is what your preoperative hemoglobin is. And iron deficiency anemia is something that is rampant, and we really don't treat it as aggressively as we should. And unfortunately, we wait until, some people wait until the blood count is so low that, we'll give you a transfusion just like you top up your car with a quart of oil when it's low, but that's not the way to treat anemia. And unfortunately, there are other problems with treating anemia in that iron by mouth is oftentimes not well tolerated and poorly absorbed, and people could be on iron for months and months and they still are iron deficient. That intravenous iron, which is probably the most appropriate way to treat someone not with iron deficiency anemia, is oftentimes not covered by insurance. So that's so iron deficiency anemia is rampant in the United States. Not as bad as it is in China, but still rampant.
And it complicates our life from the cardiac point of view, because as the blood counts drop, it puts more stress on the heart and more likely to have cardiac events and heart attacks, and it becomes a vicious cycle. And more procedures you do, that would expose you to more loss. So it's definitely a very major complicating factor.
Thank you. Dr. Risk, what are the fractions most often used in blood management, and where do they come from?
You know, there's a whole host of things, but probably the three main ones in our system, probably the two that pertain to blood management are what's called albumin and our blood clotting factors. And albumin is a protein that we actually get from the plasma. Albumin can be extracted, packaged in like an IV form, and it makes up 4%, but we usually use that in low blood pressure situations, just to simply put it. I mean, there's some other uses, but patients have low blood pressure. They have kind of a lower, what we call oncotic or protein pressure in their system. This helps boost their blood pressure up. So we can use that in low blood pressures from different causes. So the second one is the blood clotting factors, and there's a whole host of those. I mean, they're beyond this simple answer. But I mean, there's even some you can tease out, like cryoprecipitate, which has several blood clotting factors. And then the third one is globulin. Globulin pertains more. It is extracted from patients who have had diseases such like infections or inflammations, and it's antibodies is what it is. And you can package that, put an IV form, and we use it to treat patients who are low for really immune-mediated treatment and in patients who have infections and other types of diseases. But those are kind of the three basic ones we have.
Thank you. The next question was to me. What patient blood management options are available at YRMC for patients who do not want to use light blood or blood fractions? So my answer to that is going to be none. So you may say, what? There's none? Yes, because everything that we do in patients who do not want to receive blood, we do in patients who don't mind receiving blood, who sign a consent for blood. And my point of saying none is because we do everything the same way, because we feel whether you don't want blood or you don't mind blood, if you have to have blood, in some instances it might be life-saving, but those are not all that common. In elective surgery, in even emergency surgery, there are many things that we utilize, whether it be something called, well, first and foremost is making sure the patient is ready if it's elective surgery, making sure they don't have iron deficiency anemia. If they do treat their iron deficiency anemia, and pump up their blood stores so that they are in the best possible shape for surgery. During surgery, especially cardiac surgery is the poster boy of blood loss, because not only do we take your blood and put it through this machine that eats up blood and blood products, but we also heparinize you immensely while you're on the machine so that clots don't form. And then we're operating on these big bags full of fluid that we have to sew back together. So obviously cardiac surgery is bloody. So we do things like we dilute the blood as little as possible. And we take blood to do something called ANH, which is acute normovolemic hemodilution, which is just a fancy word for saying we take blood off you before the surgery and then put it back in. And why? That doesn't make sense, right? Well, the thing is that it prevents that part of the blood from going through the heart-lung machine and being hurt by the heart-lung machine. We try to keep patients in a normothermic, meaning at body temperature as long as possible, because that helps with blood clotting. We give topical hemostatic agents that help with clotting on a bloody surface. So there's a multitude of things. We give things called antifibrinolytic agents. We actually give it intravenously as well as on the heart. Antifibrinolytic agents basically fibrinolytic agents are things that lyse the fibrin. Fibrin is what makes clot. Lysing the fibrin tries to destroy the clot. Antifibrinolytic agents are agents that prevent that kind of clot destruction. So there are numerous things, but we don't offer anything different to patients who don't want blood or to patients who don't mind having blood. Beth.
Yes.
What is the current status in the USA of hemoglobin-based oxygen carriers, and what are the potential side effects?
We thought it was interesting this question came in because we just attended a conference a month ago where a talk was delivered by Dr. R.A. Shander, who's actually spoken at our event here before, and he was giving an update. So basically, hemoglobin-based oxygen carriers are a manufactured product. They are derived from hemoglobin, but he brought out they don't resemble hemoglobin at all. They're not comparable to blood because the chemistry and the function is different than what red blood cells do. These are currently not approved for general use in the US. Recently, they were approved, utilized in part of a trial for compassionate use for those with severe life-threatening anemia, for whom blood transfusion is not an option. But there are some toxicity issues along with potential hypertension and inflammatory responses to these products, and they don't know yet the impact on coagulation. So it's still something that's being researched, definitely, and they hope to see that as something they can work out any of those issues so that it could be utilized generally in the US.
Thank you, Beth. Does anybody else have any experience with?
No, experience kind of fake blood, huh? Fake blood, like fake press, but fake blood, but it's a better word is synthesized blood.
Right, to try to emulate what hemoglobin does in the body, but they just aren't totally.
I imagine the research that goes into that is extremely difficult because to mimic hemoglobin, it's complex already. The natural form's so complex.
And it's been going on for 25 years, this research. So Dale, you've been so nice, quiet, and well-behaved here. I've got a question for you. So the question was, someone said, we noted in the bio section of the program that some speakers tonight are members of the Society for the Advancement of Blood Management. Why is SABM membership beneficial to the community and to the hospital?
Well, Dr. Tibi and audience, YRMC is an affiliate member as an institution of the Society for the Advancement of Blood Management. Several of our team members are also individual members of that organization. Dr. Tibi just finished up a 2-year stint as the president of SABM just a few weeks ago. So we are very involved, but the question was why? Well, we're involved, we're a part of it because SABM delivers the science of PBM in a way that no other organization does. Throughout the year, we receive updates on our computers, we have articles, we have videos, and then once a year at the annual meeting, we have then the latest updates that have been accumulating over the last year. So these doctors come in and share their research, which means it's cutting-edge research. As an example, a month ago, Beth referred to it, we were at the annual meeting of SABM in Baltimore, Maryland. And there we heard from Dr. Jens Meyer, who came in from Johannes Kepler University in Linz, Austria. He wanted to share some recent findings of his research, which began before the year 2013. His theme had to do with the question of whether giving red blood cell transfusions to increase oxygen to cell tissue was effective or not. In the title of his talk, it was, "Is it a myth or reality?" His conclusion, I'll read it to you. In a typical post-surgical patient with a hemoglobin above 8 grams per deciliter, a transfusion has nearly no effect on utilizable oxygen. The doctor found that iron deficiency and viscosity play a bigger role. Additionally, Dr. Meyer discussed something you may never have heard of. It's called organ-specific anemia tolerance. Organs vary in the way that they tolerate anemia. As an example, he indicated that with a hemoglobin of 5, the heart and brain show no hypoxia. a loss of oxygen. But the kidneys and other tissues do. Now, if we could utilize this knowledge of anemia tolerance accurately, this would decrease the perceived need for transfusions with this added knowledge. So these things lead to better care for us. So the numbers that we get from blood testing, they're helpful, but they don't tell the whole story. We learned this just a month ago at SABM. It's recent. I will tell you this, these findings will actually improve your care at our hospital one day. 2 weeks ago, I'm about to wrap it up, Peter, the Nobel Prize for Medicine was awarded to 3 researchers who reveal the mechanism by which the cells in the body sense and adapt to oxygen availability. How do the cells know that? Well, these findings will play a major role in the understanding and treating of diseases like anemia, which we've talked about, and even cancer. Well, we can't wait to perhaps hear more about these announcements from SABM at next year's annual meeting in Las Vegas, not very far away. But I can assure you, friends, that with respect to the SABM meeting, what happens in Vegas will not stay there. So then, is science the most important thing? No, you are. Your care, your improved health, your happiness is what makes the science have real value. We feel privileged to be a part of SABM and delighted that this results in better outcomes for you.
Thank you, Dale. A couple more questions, and then we'll let you all get out of here. Beth, in what ways is donated blood used? The Red Cross says, give a unit, save a life. So
we do hear that, as was brought out at that conference. That isn't actually science. It's an advertising campaign. We notice in the community, you probably noticed, there are a lot of blood drives that happen by organizations like United Blood Services and so forth. So you probably wonder why. Why is that so constant and frequent? It seems like they bring out that blood components, they are used for traumatic injuries where there's a lot of blood loss or burns, for chronic illnesses such as sickle cell anemia. And also, though, they're used to create some of these fractions that have become a real big part of the PBM toolkit. And they're also used for research. The other fact is that these components, they don't have an eternal shelf life. Once they are out of the body, of course, they begin to degrade in different ways depending on the product. Red blood cells can be stored up to 42 days and used by a hospital in that time. Platelets stored up to 5 days. Fresh frozen plasma can be stored up to a year. So that donated blood is either utilized for these various things that we mentioned, or it will be discarded. And so that's kind of why you see that ongoing pull. But what we're appreciating is that understanding of, give blood, save a life. It's a much more complicated product to be working with. And so it's good that we have all the research and all the talented people that are doing things they can to avoid giving you the blood of another human.
Thank you, Beth. So our last question is, how important should patient blood management be in healthcare today? And I can go around the room, but I can say that I think patient blood management is a real paradigm shift. It's comparable to back in the 1800s when hand washing was not necessarily thought to be all that important, and believe it or not, it was nurses who told the doctors that this was important, and the doctors who were washing hands saw a significant improvement in how their patients are doing. So it is a paradigm shift, but much like so many things, increasing awareness and changing that shift is extremely difficult. I mean, we've been trying to change cigarette smoking for 40 and 50 years, and we're making some progress. Vaping doesn't take that long because it hasn't been around for so long. But it's important for the community, for the hospital, for the physicians, for the caretakers, and even more important for the government, in my opinion, the regulatory committees, to understand that this is something that is for the nation's, the people of the nation's benefit.
And actually, just as we speak, a man named Bruce Spiess, who's also talked here, has gotten the Florida government to seriously look into making every hospital that gives a blood transfusion have patient blood management program in place. Believe it or not, there's only about 111 hospitals in the U.S. Is that correct? About 111, something like that?
Almost 200 if you
Almost
count
200.
some of the programs.
Out of 5,000 hospitals in the United States that have patient blood management programs. So that's not a huge number. So please, Ed.
There is resistance to the science. The idea that this is the way we've always done it is alive and well in medicine. Dr. Semmelweis, who Dr. Tibi just referred to, was the doctor 200 years ago in Austria who gave the weird advice that the doctors should not come in from surgery all bloody and covered with various biological agents from the patient. He said they should wash their hands. He was run out of town for saying that they should wash their hands. It's even a name now of the Semmelweis effect, which is we have never washed our hands. We don't need to. We are doctors, after all. Excuse me. So there is resistance. There is resistance to this. And so this is something that we continually educate and educate and educate. Dr. Tibi knows this is true. I know the rest of us do too. But it's worthwhile as better outcomes are the result.
Dale, I think I forgot to wash my hands today. But no, I think just to add on that from some of us older physicians, when we trained, we were programmed. We were programmed to transfuse. We were programmed to treat numbers. And then, of course, medicine changes so much, and it is hard, I think, for a lot of physicians, whether old or young, to get out of that mode. But the science, there's been a lot of science which has been explained tonight, which has really helped. And certainly, if you take the time and really understand it, it's important. But it is hard to change that program mentality in ourselves. But we learn. We do learn.
It's easier for younger doctors like me.
That's right. I have to listen to him.
Anyone else? Well, I want to sincerely thank you from all of us from YRMC for your attendance here. It's unusual to see a community so involved in a hospital and their healthcare, and we hope that we have made it pleasurable, instructive, educational, some entertainment for you. And we can't thank you enough for your support of this community and this community's hospital. We will continue to do whatever we can to make you proud of us. So thank you very much. Have a good night.
Did you mention the trip they have to Phoenix? Yeah, for those who are...
Ladies and gentlemen, thank you for your attendance of the 2009 Yavapai Regional Medical Center Patient Blood Management and Cardiology Symposium. Provider contact is available and brochures are available as you exit. On behalf of Yavapai Regional Medical Center, we thank you for attending. Have a wonderful night.